Corrine. I'm an audiologist, and so today my plan is to first gonna go over my background a little bit so you can get to know me a little more, and then we'll talk about hearing loss, some signs, some types, and a little bit about hearing aids, and then we're going to talk some about cognitive decline and some risk factors, some signs, and also we'll talk about what a typical age-related thing would be. And then we'll also end by talking about this relationship that we're really starting to see between hearing loss and cognition. And we're going to go over some different studies that have been coming out and really what it really means for us, and, some things we can do about it. So to start off, I just wanted to go over a little bit about myself. I graduated in 2011 with my Bachelor's of Science in Psychology and Sociology. And then I ended up graduating from Illinois State University in 2019 with my doctorate of audiology. And then I was at a private practice in Dallas from 2018 to 2023. And then after that, I ended up moving back here to Illinois, and I've been at a private practice here since then. And a question I get a lot is why or how did I, get into this field? How did you even know about it? Well, it took me a little while, but I always wanted to be in healthcare because both my dad and my grandpa are retired primary care physicians. Initially, I thought I wanted to go into counseling, which with my degree in psychology, but by the time I graduated, I realized it really wasn't for me, so I ended up taking a few years off. Long story short, I shadowed some audiologists and really fell in love and saw how they not only are able to have long-term relationships with their patients, but you can really help connect people back to their families. So there are two main groups of people that test hearing and fit hearing aids, and I'm just going to briefly go over some of the differences. So you might see hearing instrument dispensers. They're also sometimes referred to as hearing instrument specialists. They take a certification course. And the criteria really varies by state. Some states require a lot of hours and then pretty hard a test that they have to take and pass. Mainly work in retail locations like Costco or some private practices, and they tend to focus on sales and hearing aids. Where audiologists, we have 4 years of undergrad and 4 years of graduate school. There are also, at the last year of our graduate work, we have a full year of a residency or externship. Primarily work in hospitals, VA, private practices, and tend to focus on patient care diagnostics as well as, hearing aids and treatment. And so some of the things I see in the day-to-day as far as red flags, or not necessarily red flags, but just signs of hearing loss where somebody might come in and say, well, just everybody's mumbling. It's not me, everybody is mumbling. Or I just can't understand what they're saying. I know they're talking, I just can't understand it. Or, well, I hear fine most of the time, but when I'm in a restaurant or in a group situation, I'm not hearing very well. That's a pretty common one. Or, their family saying they have the TV up so loud, my ears are going to start getting a hearing loss. Or, We'll see people stop going to the events they used to like to do, stop going maybe to church or a book club or something like that because, they can't really be engaged with it. We also see often ringing in the ear or tinnitus, where there's a high incidence of this with hearing loss. Oftentimes, I'll hear when I talk to people that they're just tired of asking people to repeat because it's frustrating for them and for the person they're talking to. Another thing I want to mention is if you ever have a sudden change in your hearing, so you wake up one morning, can't hear out of one ear or both of your ears, it is very important to immediately call an ENT or a laryngologist or an audiologist to get your hearing tested as soon as possible. It's rare, but sometimes, we can have a sudden hearing loss, and it's important to get into treatment as fast as possible. And that increases the likelihood that it could go back up to where it was previously. And so in general, we know that, as people get older, tend to have more likelihood of getting a hearing loss. So or having a hearing loss. So when we're looking at the prevalence, before 65, it's just about 10%. But then once we get to over 75, it's over half. So that's a pretty big jump from 65 to 75. So, if you or a family member is 65 or older, haven't gotten your hearing tested, regardless if, you think you have a trouble, it's always good to get it tested. I am seeing more and more, people getting tested before they have an issue. And that gives us something to compare to, to know, are things changing? Are things staying the same? So it's, always good to get a good baseline, even before 65, so we know kind of where we're starting at. And, hearing loss is, more prevalent in older ages, but it doesn't mean that it's normal and that you don't need to treat it. So there are, a few different types of hearing loss. And to understand these types of hearing loss, I'm going to go over the different parts of our ear system. So the first part that we're all familiar with is the outer ear. So that's the visible part with the earlobe. We call it the pinna. And then the sound will go through the ear canal and then go to the eardrum or the tympanic membrane. And then the sounds will vibrate that eardrum. And then that vibration will go through those little teeny bones in our ears. So that's the malleus, incus, and stapes, which you might have learned as the hammer, anvil, and stirrup in school. And as a side note, if you ever need a little thing for trivia, the stapes is the smallest bone in our body. So it's really teeny tiny. I know it's smaller than a dime, so it's very, very small. And then the stapes interacts with the round window that's in our cochlea, which is that snail-shaped organ there. And then the sounds travel through a membrane where there's hair cells that react to the sounds. And then that sound travels from that inner ear snail cochlea through our auditory nerve to our brain. And then you'll notice that, right really basically in the same spot, we have our vestibular nerve, which has to do with balance, vertigo, and those semicircular canals are what has those crystals you might have heard of, which are called otoconia, where sometimes they can get dislodged or kind of stuck in those canals, causing some dizziness that we call BPPV. And so that's why a lot of times when you get your hearing tested, we'll ask you about balance and dizziness and vertigo, because they can interact and they're very close together. So also when I talk about outer, middle, and inner ear, at the top of this picture, you'll see outer ear, which involves the pinna and the ear canal. The middle ear includes the eardrum and the little bones. And then the inner ear is that cochlea. So when I say outer, middle, or inner, that's what I am referring to. And so for conductive hearing loss, this is a problem with the outer ear, the eardrum, or the middle ear. So this could be, sometimes with boxers, if they've gotten their ear hit a bunch of times, they get cauliflower ear, and that can puff up basically so much that it starts to plug up their ear canal and causing a hearing loss. Or there could be a perforation in the eardrum, could be fluid behind the ear, like sometimes kids get a lot and then you have to get a tube in your ear to drain that. And so those are some of the causes of a conductive hearing loss. Sometimes there can be problems with the little bones in your middle ear as well. And then there is sensorineural. So this is a problem with the inner ear, the cochlea. This is the vast majority of hearing loss we see is sensorineural. So this is our genetic, age-related, noise-induced. All is sensorineural. And then there's mixed hearing loss, which, as you can probably guess, is a combination of conductive and sensorineural. So one example could be a traumatic brain injury. So if you get a very hard impact to the head, it can, for instance, cause a perforation in the eardrum, could dislodge those middle ear bones, causing a conductive hearing loss, as well as, direct injury to our inner ear, which would result in a mixed hearing loss. So when we test hearing and evaluate somebody, there are some red flags that we look for, and these are things that cause us to refer to a physician like a ENT or otolaryngologist for them to do further evaluation, and sometimes medical treatment like with PE tubes. So one is just some visible deformities of the ear since birth or trauma. Something like cauliflower ear, something's plugging up the ear like that, I would refer somebody to a physician. If there's been drainage in the past 6 months, could be indicative of an infection going on. If there's pain in the ear, it's not, especially if it's pretty often, that's something that we would want to follow up on. Of course, something's stuck in the ear, foreign body, occasionally we see bugs in the ears. It happens. Or just earwax just plugging up the ear. Sometimes I am able to take it out, but sometimes if it's too deep, we do need to refer to an ENT. Vertigo or dizziness, as I mentioned, especially, if the room is really, really spinning, that's vertigo. And sometimes that can be linked to medications or another syndrome or something else going on. A sudden or fluctuating hearing loss in the past month. So like I mentioned earlier, with a sudden hearing loss, to immediately call an ENT. Any good ENT or audiologist even will work anybody in that same day, ideally, to get you into treatment as soon as possible. And if you have ringing in just one ear or hearing loss just in one ear. So we expect your ears to hear about the same because of the same environmental factors, same genetics, same medication. So if we see a difference, that's, something where we want to look more into it. We also always refer to an ENT if somebody has a mixed or conductive hearing loss, because sometimes there is some treatment that could help them hear better, such as with PE tubes. So there are different degrees, or a lot of people will ask me, well, how bad is it? Is it mild? Is it severe? And so we measure it in decibels, and decibels is converted to a hearing loss scale. And for normal, we base it on average. So So from 0 to 25 is considered normal for adults. My dad is 76 and he has normal hearing. So, and all of his thresholds are 25 and above. And then after that, it's mild, which is about a whisper level. Moderate is about conversational level. Moderately severe would be loud conversation. Severe would be shouting. Profound, you're not hearing anything. And another way to look at it is in a graph like this. So here, I'm going to move my picture over to the bottom. There we go. And then, so on this picture, you can see at the top area there is the pitches. So there's low pitches to high pitches, like a piano. And then along the vertical axis, there's soft sounds to loud sounds. And then you can see like the airplane and the rock concert away at the bottom because those are extremely loud. And then you can see the two people talking with coffee cups, that's conversational level. You know, water faucet dripping is very quiet. Birds chirping in the distance would be higher pitched, definitely. And then, so an example of when we test your hearing, we plot it out like this, similar to the graph we just looked at. So again, there along the top is low pitches to high pitches, and then along the vertical axis, soft sounds to loud sounds. So we call this an audiogram. So the red circles are the right ear, the blue X's are the left. Those black printed letters on there approximate where certain speech sounds are. So what this shows us is that this person, well, mostly mild hearing loss, they're missing the F sound, the S sound, the TH, the th sound, which can make things not as clear. So just because your hearing loss might fall in the mild category, it doesn't mean it's just mildly affecting you. It can cause some pretty significant clarity issues, particularly in noisier environments. So another way to visually represent this is by looking at some text where then now where somebody with a mild hearing loss would likely be missing certain sounds is blurred out. So the way I like to explain it, it's kind of like playing Wheel of Fortune with your ears, where you have part of the word filled in that you're able to hear, but then there's a part that you're missing. And sometimes we can fill in that blank pretty easily by what we see, what we know is being talked about. Our brains are pretty good at, deciphering what's happening. But when we get into a harder environment, so a place with more noise, or if we can't see somebody's face, or if we have a hearing loss, that makes it more difficult. So, with this person with a mild hearing loss, you could probably, figure out what they're saying. Moving on to a moderate hearing loss, now we have a little more that's blurred. You're probably going to have to be really focusing more on what they're saying to really make sure, okay, I know what they're saying. And then when we get to severe, you're definitely like, I don't know what you're saying, and you're just either leaving or you're just smiling and nodding and acting like you know what they said. So when we're looking at treating this hearing loss that we just identified, sometimes there's surgery and medication. So like I mentioned before, with conductive or mixed hearing loss, trouble with the eardrum, sometimes there's procedures, or if there's an infection, medication that can help treat it. But it is most commonly treated with hearing aids. As we mentioned, most hearing loss is sensorineural, and sensorineural is permanent. And also people with mixed and conductive hearing loss also will sometimes be treated with hearing aids as well. So I'm also going to briefly go over some styles of hearing aids. This is not an all-encompassing list. This is just, in general. So this is what I refer to as a traditional BTE, or behind the ear hearing aid. So the this style is capable of producing more power. So it's good for, kids. It's more durable. Also good for people with a lot of drainage in their ears. Like I said, if you need a lot of volume. So the whole hearing aid is behind the ear. So where the ear hook is on the hearing aid is where the sound comes out, and then it goes through some tubing into a custom mold into somebody's ear. And then probably the most common type of hearing loss that we dispense is the receiver in the canal hearing aid. So it's smaller, and instead of a tube, it goes through a speaker wire that then the wire then goes down into the speaker. So the speaker is actually in the ear canal, where the previous hearing aid, the speaker is actually where the sound is coming out was really on top of the ear. So this helps us, get a little more clarity, a little more discreet as well. You can use custom ear tips and pieces or custom ear molds for retention, for dexterity, and for more volume. This hearing aid is actually engineered for a high frequency hearing loss. So when we just have a hearing loss in the high pitches, we don't want to plug the ear up too much because that's going to make your ears feel and sound plugged. So we're able to leave your ear more open while using some of your natural hearing to target the higher pitches. And then there is, custom hearing aids that we use, either impression material that kind of like getting a dental impression, but with your ear, or with an ear scan sometimes. And for this one, it fills up your whole ear, so it's definitely visible, but it's nice for people with dexterity issues. So if I have somebody with some pretty bad arthritis, gonna have trouble getting something small behind their ear and then in your ear, I will tend to go with this style for them because it's easier to hang on to. They're available in rechargeable batteries, and they're capable, since they're bigger, they can have more power and easier to hang on to. With it being bigger, they have room for an antenna, so they can be wireless as well. And then, there's ones that are a little smaller. We call these ITC. So they're less noticeable. Because they're smaller, sometimes they have a smaller battery. So they might have to be, the charge might wear down a little faster. But they are still able to be wireless, still a little more to hang on to. So, this is an option also for some people with dexterity issues as well. And then we get to the much smaller ones. We call this a completely in the canal. So these are almost completely invisible. When we get that small, it is harder to manipulate, and we have less possible room for things for an antenna for wireless, for typically have disposable batteries, the little teeny batteries you have to change weekly. And then we have the ones where it's completely invisible in the ear canal. Some canals are just too small, even for the previous one. Not everybody's ear anatomy is able to fit a device like this. There's no room for a second microphone. I think I forgot to mention the other one, the CIC also doesn't have room for 2 microphones. So there's a little less directional capabilities with them. I think a lot of people come into my office thinking they want this one. But once you learn more about it, you might realize that maybe it's not the right fit for you, particularly if you have, some good hearing in the low pitches. This is gonna plug your ear up a little more, so you might not end up liking the sound quality. And then with each style of hearing aid, there's different levels or tiers of technology. So they vary on the different features and how much noise reduction they have. So the higher tiers have just more automatic changes, more noise reduction. So if you think about a soundboard where higher levels of technology have more knobs and switches than the lower levels. And so it's important to consider your lifestyle. So if you're, lead a quieter life, you might not need a higher level. If you have a more severe hearing loss, or if I test somebody's, hearing and I see they have trouble, repeating words back to me when I turn up the volume, that might be a clue that it might be better to go with a higher level of technology. And then we should also consider finances. The higher levels are, of course, more expensive. And I always tell everybody that I talk to, something's better than nothing. So if you need to go with a lower level of technology for it to make sense with your finances, then that is the best option for you. So there also are, for some cases, some implantable hearing aids. So one is probably people are most familiar with, which is a cochlear implant. So an ENT would be implanting electrodes into the cochlea. So if you remember that snail-shaped organ that's in our ear system, electrodes are implanted in there. It's permanent and it converts sound into an electrical signal. So I always tell people, if they're thinking about getting a cochlear implant, that expect it to take at least a year to get used to the sound. It's completely different. A lot of times when people first have their cochlear implants activated, they think it sounds kind of like Daffy Duck. Just sounds different. So it takes time to get used to it. So I think I've had time to time people think cochlear implants, maybe they're like LASIK for ears, but it's just completely different. And for some people, there are bone anchored hearing aids. So this uses bone conduction. So if you've ever seen those headphones that don't go in the ear, they go kind of right behind your ear. It uses bone conduction that bypasses the middle ear. So if you remember, people with a conductive hearing loss have trouble in the middle ear. So if we're able to bypass that, they're able to hear well. So it's a small segment of people that really, for both of these, are qualified for or good fits for. And you've also might have seen recently an uptick in maybe ads or things that you've seen advertised for over-the-counter hearing aids. So a few years ago, there was legislation passed that made it legal for different companies to sell over-the-counter hearing aids. Now, previous to that legislation, we've always had these on the market. They just now can legally call them hearing aids, so they aren't necessarily new, but I think they're more widely known now. So, these are ones that you can find online or at some realtors, or like at Walmart or Walgreens. They tend to be lower cost and don't require an office visit or a hearing test. Some of them will have you do a hearing test on an app while you walk you through it. It's unclear on how accurate that test is. And a lot of them I've found they just take all the sounds around you and crank it up. Where what we use as hearing care providers are prescriptive hearing aids. So these are based off of a hearing test. So most people don't hear the same across all the different pitches. So we want to use your hearing test to make sure it's programmed appropriately for you. So that way at each tone, it knows how much volume you need. And they also have automatic changes. So when you go into a different environment, they'll make some automatic changes. Definitely not perfect, but can help, particularly when you're in a harder situation. We also will do real ear measurements, which means we'll put a tube that has a microphone in it in your ear canal with your hearing aid so we can measure how much sound is in your ear canal. So it's like yelling down a narrow hallway versus a wide hallway. There's two different loudnesses. And the same we see with ear canals. There's lots of different shapes and sizes of ear canals. And so if we're not measuring that sound, we're just guessing how much sound each person is getting. So if you or a family member are ever looking at new hearing aids, and a good question to ask that provider is, do you do real ear measurements? And if the answer is no, I would not trust them. So now that we've gone over some about hearing loss, some treatment, and now I want to pivot to talk about some cognitive decline. I know, it can be a hard topic to talk about, but I hope after today you can feel a sense of empowerment of things you can do to, help your overall cognition. So this is not just forgetting things from time to time. This is memory and cognitive issues that are significantly interfering with your daily life. One of the most common causes that we know of is Alzheimer's disease. So it's not a normal part of aging. It's not just like I said, not just, oh, forget a few things. It's something that is significantly interfering, and it also is progressive and gets worse over the course of several years. So the Alzheimer's Association has, on their website, 10 warning signs of Alzheimer's disease, and we're going to go over each of them. And then we also have a typical change that we'll contrast it with to hopefully not, scare us into thinking, oh, if I forget something, I don't know. That I don't want any panic, but I think it's good to know some warning signs for yourself, but really for, the people in your life. So, not to sound like a broken record, but this is the memory loss that disrupts everyday life. So this is forgetting new information, dates, events, somebody who's keep having to repeat the same questions. I've seen that sometimes, where they keep asking the same question and then a few minutes later ask the same question. So, it's kind of like that short-term working memory is having some trouble. So a typical change would be, forgetting something, but then maybe later on that day, you're like, oh yeah, that's what I was gonna ask. And that is, that's a typical thing, happens to me. There could be challenges in planning or solving problems. So this could be trouble with numbers or following plans. So following a familiar recipe or keeping up with monthly bills. So if there's, a family recipe that someone has made so many times over the years, and then all of a sudden they're kind of like having a little trouble, that would be kind of a warning sign. Doesn't mean anything for sure is happening, but it's a warning. Typical change would be, sometimes occasional errors in bills. Maybe you forgot to update your credit card information and a bill went unpaid, and that can happen. So there can also be difficulty in completing familiar tasks. So something that somebody has been doing daily, nothing new, and then starting to have trouble with it, or whatever favorite game maybe they like to play, is all of a sudden having some trouble remembering how it goes. That is a warning sign. And a typical age-related change would be, occasionally needing help with technology. Technology is changing fast. It's hard for me to keep up with it. So, I know with my parents, sometimes we're having to help them figure out a phone issue or something like that. That is normal. There can be confusion with time or place, like forgetting what the season is, lose track of dates or passing of time. I think the typical related change is forgetting the day of the week. This happens to me a fair amount, especially if my routine is thrown out of whack, then I might have trouble remembering what day it is, but to not remember what season we're in would be something different. So we also see trouble with visual images and spatial relationships. So there can be trouble with reading, trouble with balance, vision changes, and we can see some of those vision changes include spatial relationships, so that can make driving more difficult. And a typical change would be getting cataracts and needing to get those taken care of. So there can also be new problems with words or speaking or writing. So that's, thinking linguistically, there's changes there. So there could be trouble following a conversation, trouble joining conversations, maybe just not quite understanding how the conversation is flowing. And again, might often repeat themselves, ask the same question, not really understanding what is being talked about. And a typical age-related change is having trouble with word recall sometimes, not being able to find the correct word right away. So then there's also, of course, misplacing things and losing the ability to retrace steps. So might put something in a really weird place, or might even accuse others of stealing. So, and with a age-related change, you might lose something like your keys, but you're able to retrace your steps and go, okay, I came in from the back door, put my bag down, and then I went into the kitchen, got a glass of water, and able to kind of work back through to try and find what you lost. And, especially with putting things in unusual places, that can happen sometimes, but particularly if it's recurring as well. There can be decreased or poor judgment. So there might be some poor financial decisions or poor hygiene. So I remember one time with my grandpa that somebody came to the door and asked for the deed to the house, and he signed over the house to them. That was a red flag for us. That his judgment was not going well. Where, a typical age-related change would be, to maybe make a mistake like forgetting to get the oil changed, or forgetting to get new tires when the treads were down, something like that. We also see people will start to withdraw from work or social activities, especially things that they used to enjoy. And again, kind of all these are very similar, but having trouble following a conversation. And something that can be typical would be sometimes to be uninterested in family and social activities. I think, as we get older, we're not feeling the need as much to push us to do things that we think we should do, but maybe we really don't want to. And it's kind of like, well, I'm just not going to do it because I don't really want to. And there can also be changes in mood or personality. I think this is one that is often depicted in the media and TV, where, somebody with cognitive issues, all of a sudden they get really mean and they lash out. It can happen, doesn't always mean that it will, but it can be confused or suspicious, just depressed or fearful, easily upset. And something that might be typical would be, sometimes when we get older, we get a typical or a specific way we want to do things, and we don't want that to be interrupted or changed. And sometimes that can be a little annoying. You can get a little irritable. I think that's normal. I also want to highlight some risk factors. So there are several different factors that we see that increase somebody's likelihood to have cognitive issues. So one is just age. Kind of like duh, but the older you get, the more likely you could have cognitive issues. there is a genetic component. So having a family history, I have a family history, so that does play a role. There also are certain long-term health conditions that we see increase the likelihood. So things like diabetes, hearing loss, vision, head injury, high blood pressure, high cholesterol, depression, all seem to contribute to an increased risk. There's also some lifestyle factors. So this is one I want to highlight because these are things that we can do to help lower our risk. So, and a lot of them are probably not a surprise. So this is physical activity, smoking, alcohol, social isolation. So getting out and being social is important to our cognitive health. And women, we tend to be more at risk. We don't really know why. It just tends to be women. Could be that just women tend to live longer, but we don't really know. And then there's also something called cognitive reserve. So this is the brain's ability to learn and do new things. So this is where we talk about keeping the brain active. So learning new things and keeping your brain, learning new ways to do things. So we find that people that maybe just sit on the couch, watch TV, they're not learning, they're not reading, they're not, keeping their brain active, doing crosswords, things like that, that they tend to be more at a higher risk. So now there are some similarities that you might have seen as we went through, especially some of the signs of hearing loss and dementia. So we see in both asking people to repeat, and we see people withdraw from social events. Are we repeating and withdrawing because we're having cognitive issues, or is it because we just can't hear? Or it could be both too. So, and then also along with that, depression and just trouble following conversations. One thing I often say in clinic is you can't remember something you can't hear. So it's always important to get hearing checked to see, can the brain even hear it? And that's certainly going to contribute to a lot of things. So now that we've talked about hearing loss and then some of cognition, we're going to go over some of the different research that we've seen that have looked at this association. So one such study looked at if age-related hearing loss is a modifiable risk factor for cognitive decline and dementia. So they took a meta-analysis of 36 studies. So a meta-analysis takes already completed studies, pull all those samples together to get a bigger data set and more robust conclusions. So they had a lot of participants, and they found that there's a significant association between hearing loss and cognitive impairment and dementia. So this means people with hearing loss were more likely to have also cognitive impairment of some sort. So they concluded that it is a possible biomarker and modifiable risk factor for cognitive decline, impairment, and dementia. So, while this is interesting, it is an association, which, gives us insight, gives us an idea about a relationship, but it doesn't mean, and we can't say that hearing loss causes dementia or dementia causes hearing loss. And then there's a Baltimore longitudinal study of aging. So they had a prospective study of about 700 individuals that they followed over the course of 12 years. So they assessed them at the start and then after 10 years. And they looked at the hearing loss and cognitive issues. And what they found was that people with a hearing loss were almost twice as likely to develop dementia, which is a huge difference. So, and they also found that this increased with the severity of hearing loss, which means, when we get to moderate or severe hearing loss, we're way more likely to be diagnosed with dementia. So, but also we can't say, for sure, is it the function of the hearing loss, or is it that these people with a mild to severe hearing loss are not as active, not using the brain as much? We don't really know, but it is something that causes us to pause and go, it's something to keep in mind. So there was another 25-year perspective study that with almost 4,000 participants over 65 at the beginning, just under 1,300 reported problems with hearings, and the rest did not report. They found that the people who reported hearing problems showed an increased risk of depression, dementia, and disabilities in activities of daily living, which is like bathing, cleaning, cooking, that kind of thing. And a more recent study that was just reported on a few months ago and last year, they have an ongoing study of a cohort that they're following. It's community-based, 3-generational, and they evaluated the brain volume with MRI. They also looked at cognitive performance on neurophysiological testing, and then they looked at, the incidence all-cause dementia, and they conducted hearing tests. So when they looked at their results, people with a mild or greater hearing loss were associated with smaller brain volume, greater white matter abnormalities, and just an overall decline in executive function. So this is showing that there's seeming to be this physiological difference in people's brains that have a hearing loss. So they found that any hearing loss was associated with a 71% increased risk of developing dementia. The good news is they found that hearing aids mitigated these risks. And so they concluded that midlife hearing loss might be an early biomarker of brain aging and dementia, and another just warning signs or risk. And then so now that we've had several studies that have shown this relationship, I think another natural question to ask would be, well, do hearing aids help? Do hearing aids help keep the brain active and combat against this increased risk of dementia? So the National Health and Nutrition Examination Survey looked at this. They had almost 10,000 participants, and they evaluated them in 1999, and then in 2012. They tracked their hearing loss and reported hearing aid use. And they did adjust for confounding variables like demographics, degree of hearing loss, and medical history. So they found that hearing loss was an independent risk factor for mortality. So this means, they eliminated other variables, and it seemed to be that hearing loss was independently associated with just an increased risk of death or other diseases. But they found that those that reported regular hearing aid use, that mortality risk was lower. They found that with treatment with hearing aids, those with hearing loss showed no additional risk factors of dementia compared to those with normal hearing. And again, we could argue that it's the hearing aids themselves keeping the brain active. If you don't use it, you lose it type of thing. Or it could be that people with hearing aids are just in general the type of people that are using their brain more. They're taking care of their health. They're, ones that are more active and social. And so all that contributes to it. Most likely it's both, but that we can't say for sure. And they also found that the global cognitive scores improved and improved short-term memory, attention, and as well as the long-term episodic memory as well. And they estimated that dementia rates could be decreased by 8% if all hearing loss was treated. So we also have a lot of studies on different benefits for hearing aids. I won't talk about all the individual studies, but we see an improved quality of life, and that goes along with decreased depression because we're not feeling so anxious socially, that we can be a part of the conversation so that we're able to, participate with, less anxiety. It might seem also, with improved speech understanding, it might seem like duh, but this goes beyond just, things are louder. This goes more of like, are we understanding speech more? Understanding what somebody's saying and just hearing it are two different things. We also see decreased stress. So we have lots of research that has shown that people with a hearing loss are more tense and tired by the end of the day because they're having to use more concentration just to hear, whereas those of us with normal hearing, we're not having to do that. So I have seen that with some people that, especially ones that are still working, they'll come to me and say, I'm so stressed at work, it's hard for me to understand. And then after they get hearing aids, you can just see that they're just more calm because they're not having to use so much concentration just to have a conversation. So this ACHIEVE study is probably the reason you have seen more about hearing loss and cognition out in the media. So this was published, I think, a couple of years ago, and the reason it was really in the media is because it's the largest randomized controlled clinical trial of hearing aids that looked at this association with cognitive decline in older adults. So when we're looking at research and levels of evidence, randomized controlled clinical trial is the highest level. So underneath, are the studies that we've talked about up until now. So these are, associations, just looking at kind of the qualitative data. Like, okay, we see this association, there's a relationship, that's interesting, but we can't really draw any more conclusions other than seeing a relationship where controlled clinical trial were able to glean more information. So they looked at adults with mild to moderate hearing loss, and they separated them into two groups. So one group had instruction, treatment, and counseling with an audiologist, and then they had a comparison group where they had health education with just a general health educator. And then they used MRIs to analyze changes in the brain after 3 years. And then what they found was that a hearing intervention by an audiologist slowed cognitive decline by almost half. So that is, a great increase, like a great slow decline. But it is important to point out that this is for those with already an increased risk. So if you think back to our risk factors, those are the people that we see this with. So those with, general healthy participants with less risk factors, we didn't see any effect. Our theory is that, it will take more years to see this effect in people that aren't as at risk. But I think this is a great thing to see because if we know, okay, I'm at more higher risk. My mom is at higher risk because she has diabetes and her mom has Alzheimer's. And so she's at a higher risk and she's, female. So that's why for those people that know, okay, I'm at higher risk, something that I can do is if I know I have a hearing loss, then I can look at and so again, they are continuing to follow these people, and so we'll hopefully get some more data on that. So to summarize, what we can't say is that hearing loss causes dementia or that dementia causes hearing loss. We see that association, but more research is needed to investigate that link. Kind of a broken record, but want to be careful about how we talk about it. But what we can say is that those with untreated hearing loss are more likely to be diagnosed with dementia and cognitive issues, and that treating hearing loss with hearing aids could mitigate the increased risk of dementia, especially for those already at an increased risk. So overall, what I want you to take away is that, it's important to be proactive in your cognitive and hearing health, to talk to your PCC or PCP about getting dementia screenings, and also get your hearing tested. It's never too early to get to see where it's at, and probably most importantly is to not wait to get into treatment with hearing aids once they are recommended, and that way we can be proactive and keeping our brain healthy, stay curious about the world around us, try to learn new things, and being proactive in our health.